Well, hello everyone, and welcome to this health tech nerd discussion with Stacy, who's the CEO. And we are today talking about ICHRAs. And so, obviously, employer-sponsored health insurance has been getting a lot of press lately. Kaiser just released their annual survey. Employer average contribution for a family of four was $20,000, which is a lot of money if you're the employer. And so, ICHRAs are one of those things that comes up and gets discussed a lot. And we thought it would be great to have the CEO of Venture on to chat about ICHRAs. With that, I'm going to pass it over to Kevin, and he's going to kick us off with the first question.
Oh boy, let's go. Stacy, welcome. We're excited to chat. So, Martin and I tend to follow the news on a regular basis. And one of the articles that we caught our attention a couple weeks back ago now was it seems like a small county in West Virginia made a decision to move over its 265 employees, I think it was, from a group plan to ICHRA plan. And I'm curious because, so like, as I read the press release, high level takeaways. They essentially seem to get priced out of the group market. Multiple plans did not offer coverage. It seemed like rates were going up, and it seemed like ICHRA was a great offering to have access to three different carriers and 37 different plans and lots of personalized options for members. It's seemingly not like a much higher price. And so one of the things that I am curious about in that is reading that sort of news headline as a kind of casual observer of the ICHRA market and reading and trying to sift through all the narratives. Like it seems like we've got the ACA, which has a lot going on at the moment, but one of the big concerns is sicker risk pool, higher prices, healthier folks leaving the market. And then it seems like conceptually we've got this narrative of ICHRA is a great way to get small group, healthier lives into the ACA market. That should help stabilize it. Like awesome, good for long run risk pool, right? And then I read about this county in West Virginia, and I'm like, but that doesn't seem like the healthier, like say, like the risk pool that is stabilizing the exchanges. It seems like sick risk pool that might actually exacerbate the problem that is potentially happening in the exchanges. And I'd be curious how you process that, sitting in the ICHRA space, how much you're seeing things like that, how this dynamic is playing out as you see it.
Yeah, well, all great questions. And I think first it might be helpful to give kind of a lay of the land.
Mhm.
So, ICHRA is, in my opinion, and also our experience, an all of market solution, meaning that we do see conversions from the small group, which employers under 50, the fully insured groups that are maybe mid-market, so like 550 employees to like 500 employees. And then also the self-funded employers who can range anywhere from 500 in the low end to the tens of thousands of employees. And the largest group we have in pipeline is over 100,000. So like they're like just to give you a sense, smallest employees one, largest employees, largest potential is huge. Uh, that matters. Those segments matter because depending on where you fall on group size, you're buying a different product. So if you're, when they talk about small businesses, they're talking about businesses with 50 employees or less, which are community rated plans, just like the ACA. And those are the amount of people who are on fully insured small group plans is shrinking. And then you wait, they're going usually going off to level funding or some sort of self-funding arrangement. And so what you're seeing is the groups that are on a fully insured plan for the small group, that risk pool is getting smaller and smaller, getting less healthy, and it's a fraction of the size of the individual market. So in every state, it's like it could be anywhere from like 1/10 or less this of the size of the individual risk pool. So even though the individual market has historically been the market of last resorts where you go if you don't have employer-sponsored healthcare and historically has absorbed some of the highest risk claimants. It's because of that dynamic on with small group, it is you basically have small group fully insured death spiraling and the market splitting between ICHRA and the market splitting between level funding. Now, for the West Virginia case, that would fall under a large group product. And actually, you see another window in ICHRA where it basically groups between 100 and 300. They're usually on a fully insured product. They're not usually, don't have the resources or budget financial situation to self-fund or claims history. And then they're really hard to like, they don't fit fully insured. They don't really fit self-funding. That's where also you're seeing a lot of ICHRA uptake. So those are the two market pulls I see. And so when I hear that West Virginia story, I'm not shocked. It is a concern. Like, yes, you are seeing the higher utilization groups go to ICHRA. That's a thing. But a higher utilization group, just for context, might mean one or two people, one person had cancer, one person had a NICU baby, but then the 100, like 190 people are actually healthy and low utilizers. So even still, and in general, when I talk to my actuary friends, they talk about how even being able to go to a job every day, that's a marker of health. So the worst risk in the employer risk pool is still better than the individual market. So it still does lift the tides. Anyways, that was a really long-winded answer.
Yeah.
But I
No,
think like segment matters. And then also thinking about like, yes, high utilization for a business doesn't mean everybody's a high utilizer. It means that they maybe have like one or two people can throw the whole plan off. So yeah.
yeah. And can I, the second part of that question on this county, like just mechanically, it's a
Mhm.
little confusing to me how all of it works. Like they talk in the press release about how there's three carriers and 37 plans, and then I go look at the ACA plans for that county in West Virginia, and it doesn't seem like there's like 37 different plan designs. So like, I'd be curious, like for middle America who's switching from Highmark group coverage to an ICHRA plan like this, like they don't strike me as the San Francisco startup that like is super
Yeah.
excited about their eight sleep, like going like what is the transition like? Like are they in just a private portal that ICHRA brokers are offering that is, and are those on exchange plans? Or are they like what plans are they getting access to there?
That depends on the platform.
Okay.
So for us, it's both.
Yeah.
And we actually give the opportunity for the broker or the employer to decide whether it's on exchange only, off exchange only, or
Hmm.
both.
Okay.
Sometimes we see employers do off exchange only, but usually the default is to offer both. I think most ICRAs are focusing more off exchange direct from the carrier rather than on exchange, candidly. So the price in the past, the plans were almost identical, 95% the same between on exchange and off exchange. This year, we are seeing more carriers diverge in strategy and
Hmm.
be more, think about doing their off exchange book with ICRA in mind. So
Hmm.
thinking about designing for the employer space. So it is different. Your average consumer is across the country is going to see 100 plan options across like 5 to 6 carriers. West Virginia is the most expensive in the whole country. And it's usually 2 to 3 carriers, so it is like few less competition there. But
Yeah.
that number doesn't phase me, but that's also, yeah, I guess I'm in it every day. So that's about right. It depends on how the what platform you work with and how they configure it, to be honest.
And for those of us who, for those of us who are familiar with the ACA, we think like the on exchange is
Yeah.
what we think of when we think of the ACA. Can you talk a little bit about what an off exchange plan is and why there's that divergence?
Okay, the only thing that's different that off exchange plans are also ACA plans. Spoiler alert. Same risk pool, same process. Like every year they go through the process of the states put out this is minimum essential benefits, this is what we want to see. The carriers say, hey, this is our offering, regulators approve. The plans are the plans, and the off exchange on exchange refers to where they're sold. So on exchange is sold through an exchange like healthcare.gov or Cover California. Off exchange is sold directly by the carrier. You do see some carriers, namely Centene is doing this, where they're actually creating different subsidiaries and basically filing. Then with that, they're able to have more deviation between their products. So like Ambetter Health versus like Ambetter, I don't know the brand like off the top of my head, but they're different subsidiaries filing. But on exchange, off exchange basically refers to how the plan is sold. Everything else is the same.
That's really helpful. And the impetus for this conversation was Kevin sent me a LinkedIn post that you posted, which we loved, which was benchmark silver plans went way up. Friends don't let friends use ICHRA money to buy on-exchange silver plans. Can you talk about what drives that dynamic and why friends don't let friends buy on-exchange silver plans?
Yeah. So the long story short is you could see, okay, like California, silver 70, which is like you can find it on exchange or you can find it off exchange. It's going to have anywhere from like a 15 to like $50 price difference. And the reason comes down to the tax credits. So back in the first Trump administration, there was a regulatory change in how the subsidies were are paid out, basically. And then to carry the difference, this phenomenon called silver loading started to appear, where basically the carriers would jack up the price of the silver on exchange silver plans because they basically, if you get subsidies, which 90% of the individual people who participate in the ACA do, you're actually getting probably a plan that qualifies you for cost sharing reductions, which means that your plan is actually that silver plan is more like a platinum plan. And then how do you pay for that if you're the carrier? How do you pay for all those additional benefits? And so they raised the price. Part of that also was the consumers not really seeing the price because it's subsidized. So you could kind of see it like the price goes up, but the consumer doesn't see it because you see the net price after tax credits. And that's called silver loading. So you see it in ICHRA because you can't use tax credits. But off exchange doesn't you don't qualify for tax credits. And so there's no reason to, increase the price. And then usually you see the real price of what that silver plan would cost without kind of these like kind of games. And this year, the thing that's in shut down the government in the news is the fact that the expansion of the tax credits are ending on December 31st. And so my read of what's going on is that both regulators and insurers have silver loaded even more. And what it means is that this was their way to close the loop between to soften the financial blow to consumers because that silver plan decides how much tax credits you receive. So it does mean that like if you stay on that silver plan, yes, like you're still getting probably similar amounts of tax credits as last year. It means you need to shop. That's the game. And then that's a challenge for every broker in the country to like figure out how to tell your clients to do that. But it's a total like basically the insurers in the ACA, like they're so smart. They game the crap out of this system. And it's a game that's being played right now this year. And also it's so technical, right? I don't know if that even how I explained it. If there's any questions, happy to try it again. But it's so technical that like it's never going to make the headlines. Or maybe
Yeah.
somebody watches this and it does, but whatever. Like it's not going to make the headlines because it's like it's so hard to understand. That's what happened. But it's basically a way to close the loop between the expansions ending and making sure the consumer is like they've softened the blow, so to speak.
That makes sense. That's why when people talked about, back when CSRs were not getting funded by the first Trump administration, that's why they talked about the tax credits getting a lot more expensive because the tax credits were based on the silver plans. If you make the silver plans a lot more expensive, then you're going to have to pay more in tax credits.
Yeah,
And
yeah. There's
here
no
we
free
are.
lunch, right? Yeah.
On those off-market plans, so the buyer for an off-market plan today is someone who's not eligible for a tax credit, so that maybe 10% of folks. Are there, and you said it's mostly the same. Is there any reason why someone outside of an ICHRA arrangement, I realize it's ICHRA A arrangement, might go to a off-market plan? Or you mentioned now that you're starting to see some benefit divergence, but what does
Yeah.
that market look like in the past?
I mean, it's always been there. Um, Weird fact. I mean, I grew up on those plans. My parents were small business owners. So like this was pre-ACA. So it's existed before the ACA. It's existed, it's now there post-ACA. So there's always been like a contingent of people who either couldn't get insurance from their employer or who were small business owners or entrepreneurs of some sort. So and then basically it's about income. So if you don't make, $62,000 is the cutoff, it's the cliff. If it's 62, you're over $62,000 as a single person, then uh, you don't have that much material benefit of going through the exchange. You could go directly to the carrier. It's same. So, um, yeah, there also are some slight benefits this year. Like, state of Connecticut and Anthem has the same PPO on Access Health as they do off exchange. Access Health has a limited Blue Card PPO. Off exchange has a broad network Blue Card PPO. So like there are like some things popping up in different markets. It's market by market, but um yeah,
Interesting.
like it really depends. And there is a subset of consumer, we've been dabbling with ACA for 5 years now, who just like they see healthcare.gov and they're like, oh, I don't want to deal with it, or they like go to one of the state-based exchanges. And actually, I was helping a friend earlier this year, and she was like, this exchange, I won't name names, it wasn't healthcare.gov. She's like, this doesn't look real. And so it's like, let me go to I'd rather just pay the money and like I don't want the tax. I don't want to, no. So there's basically all these UX issues with like the shopping experience that I think still freak out consumers and then there's political element, right? Like some people are totally okay buying directly from the carrier, even though that's still an ACA plan, but they don't want to have anything to do with the marketplace. So,
Stacy, can you walk through the game theory of the off exchange plan with the broad open access network versus the on exchange with the narrower network? Like, is somebody in a carrier looking at those two populations and saying, because of the difference in this in who's buying um not on healthcare.gov, we think that there presumably is a difference in behavior that they expect that allows them to underwrite a open access PPO
yeah,
versus the HMO, right? Is that
yeah,
the reality?
100%. Yeah, and we do read the actuarial memos. We are, as this community would, as well named health tech nerds. So,
Mhm.
but in the memos, what you see usually is lower morbidity scores. So they're assuming that you're hiring. Usually, as you go up in income, you do go up in a few things, lower morbidity, but also higher utilization. So, but even though you have higher utilization, it's usually on prevention or lower cost items. It's less about like delayed care, and then all of a sudden when you need care, it's very expensive and catastrophic. It's more you're like an employed population goes to the doctor more than a self-employed population. So that's what we're seeing. But the delta in morbidity, that like that's basically where you can kind of you have savings as a plan, and then you could play around with network access or
Yeah.
broadening the benefit.
So for plan strategies moving forward, like I think about Oscar and some of the more personalized plan designs that they're coming out with and whatnot, would you expect there to be more of a divergence between the two markets and the various kind of personalized plan designs that are coming out across those, or is it going to be more carrier specific in how they view things? Like how does
I
that
think
play out?
it's both, to be
Yeah.
honest. So like, what's your overall stance on the ACA? Do
Mhm.
you want to grow? What do you want to do? But I actually do think that like off exchange, you're going to see more divergence and there's opportunity to create something we talk about with carriers all the time is how do we be a data partner to help you to like basically uh, think about the future plan design and design for the ICHRA market and create better supply demand fit. But on exchange, they're actually limiting the number of plans because there's a phenomenon called shelf stacking. I don't know if this term has come up in your world, but
No. What's shelf stacking?
okay, so you log in first page of healthcare.gov. This is so prevalent. Like actually go to Miami, Florida, type in a Miami zip code and then you'll see like blue, like on the whole page, right? And then makes the consumer think only that plan is available. But then every single carrier basically tries to do the same. So they like end up issuing like 70, 80 plans and they're like not materially different. It's It's basically to like fill the page and then just fatigue you out of searching. So yeah, to make you think that that plan is the only option.
Back to your point earlier, that plans are really smart and know what they're doing. It's a good example of that, right? You follow the consumer behavior.
Yeah.
I'm curious, picking up on the topic of plans. It's earnings season here. We've been talking a lot about earnings calls. Oscar and Centene have obviously been two of the big proponents of the ICHRA market on the public markets. Oscar's tomorrow, so we get to hear from them. Centene, it was interesting to hear like what I perceived as a slight tone shift where Sarah Lennon has been traditionally out in front of the ICHRA market talking about it as biggest proponent. It was she didn't mention it all in prepared remarks, and then there was a question about future of ICHRA, and it was as I heard the response, we're very excited about it. We're very bullish long term. The short term kind of dislocation in the ACA is more of a question mark. And the quote I wrote down was we're hopeful that this administration is also very interested in ICHRA, which to me is it's an interesting, uncertain answer. Indicative of, the previous Trump administration, their support of ICHRA, that it should be supportive of ICHRA conceptually. But I'd be curious your read of the sentiment around ICHRA in the market at the moment, the questions around the ACA market and how that is impacting momentum as you're seeing it for the overall market.
Yeah. So, the questions around the ACA definitely, they're a headwind. I think ICHRA CEOs, we play a game. We're like, like, is it a headwind? Is it a, like, do we say it's neutral? I'll be blunt here. It is a headwind because basically our ability to sell ICHRA depends on our ability to convince the market that the ACA is stable and also that the plans are good, the supply is good. So for many of the groups we serve, what we found was that actually, if you talked to me 4 months ago, honestly, I was nervous about this open enrollment based off of what we were seeing. The rates weren't as bad as we thought, but they're still bad. And we're working with the large groups. What we're seeing is these are groups that where the plan's already death spiraled and they've got nowhere else to go. And one of our clients got a 44% increase and stayed with us. And so we're grateful to them, but it's because the group plans were double. But if you have a choice, we saw another group walk away from a $52 million cost savings that because they were nervous about, obviously that was a larger group for that size of cost savings. They're like, we want to wait another year to see how the ACA does because this, before we commit to this kind of change, then, we need to make sure that's stable. With small groups, it's not an issue. So there's still a ton of momentum around ICHRA. And right now we've got a historic level of people shopping. So it's 10x the volume of what it was last year. So I'm not worried about my company's growth. I'm not worried about the market's growth, but definitely if I'm a Centene or an Oscar looking at like all of the Venteurs of the world and aggregating us all together, definitely we probably could have achieved double what if we had a bit more of a stable market, if not triple. So and also ICHRA's just so small given the earnings of any carrier at this point. So we're not material in moving the needle for them yet. So like she's valid in like not mentioning it. And I think I really am grateful to both Sarah London and Mark Bertolini for creating this awareness, but it's been more aspirational than it has been real.
Yeah.
I want to kind of double click on that tension. So you're talking about these employers who have this opportunity for incredible cost savings. Like you talk about $52 million is not sofa money. And then, but they're thinking about their employees and they're nervous about the change management. And then I'm sure there's also their employees are hearing about all of the things going on in the ACA market, and it's pretty intimidating. I'm wondering if you can kind of talk us through how your clients balance these two things. Like there's all of these potential cost savings, but also there's this potential pushback from employees.
So interesting thing first on the employee side, there's an independent research study by Daft Research that shows there's a 32 point bump in NPS between group and ICHRA. and it's all related to choice. And actually, it was a carrier who brought this attention to me. And it was the CEO of a ACA, like book of business at one of the larger carriers. And this person said, I can't believe that people like they're all materially like they're on narrower networks with HMO, PPOs, or HMOs and EPOs and whatnot. But they're happier. And so that 30 point bump is due to choice and like that control, that sense of control. So that's really telling in the market. The thing is that's not how brokers or employers buy. So like that's where I think that the part I almost think of that scene in the beginning of the Mean Girls, the original one, 2003, 2 or 4, whatever it was, where like she's going to school for the first time and her parents are like, "Oh my God, are you gonna be okay?" Like that's sometimes what it's like talking to HR when they're doing the ICHRA transition. It's, oh, your employees are gonna be okay. They actually really want to choose. They want to do this. But there's a huge mismatch in how employers and how brokers sell, how employers buy, and what employees want. All of those are different. So it'll take some time to actually, I thought I was on a panel with Alan Silver from Centene about 2 weeks ago at Health. And in the prep, he was part of the private exchange market before in his past work. And I asked him, I was like, wow, is ICHRA different? And he said the biggest lesson learned was, I thought this was so smart. Um, it was this issue of what employees will buy versus what employers will buy are different, and what the carriers need to do to grow, if they want to grow the ecosystem, is put more plans in the ACA that look like what employers want to buy, even if there's like no uptake on those plans. So
Just so you can point to it and say, hey, look, we've got this open access PPO if that's what your employee wants to buy. Yeah.
correct. And actually, every market where there is a PPO, we do better on a sales point of view.
I buy that.
Kevin, any last questions from you before we start to wrap it up?
I was maybe just one like conceptually for me that on the 52 million of cost savings for the employer, how like what's the as I think about overall costs, it seems like okay, if employer is saving $52 million, like somebody's got to foot the bill for that. Is that going to the employee? And really, is this just passing costs through to them to give more guarantees for the employer? Like, how do you think about that equation and where cost savings are coming from and how employees aren't footing the bill for more in these types of plans?
I think well, I know it's coming from two places. First, if for a group that size, it's about they're self-funded, they've got stop loss. So you're moving to, most ICHRA markets that are hot, like there's a public reinsurance program. So it's almost like you're moving your private stop loss to like public-private stop loss, so to speak.
Yeah.
That's part one. And because the ACA has grown to the size it is, then the math works differently, especially because the government is always subsidizing the highest risk in those risk pools. So then the second area of cost savings. Ooh, this one's very, I don't know, it's not talked about a lot, but it's real, is provider reimbursement. So the rates, like the reason why Centene has such an incredible position is they're leveraging their Medicaid contracts. And that though, over the long term, um, like employer-sponsored healthcare, the commercial plans subsidize both Medicare and Medicaid and the ACA today. So ACA is priced closer to Medicaid than it is in Medicare, closer than it is to commercial. That will change over time as this matures, but because it basically makes that price discrepancy more visible. So it's really the provider contracting. That's where you see the biggest arbitrage.
That makes sense. So providers probably aren't going to like it if
Nope.
it gets a
Nope.
ton of membership.
But I think there is ways for them like we partner with many, and there are ways to win, and there's ways to think about like different financing, different way to pay. I think that's also where ICHRA to me in the long term, when it as to fulfill its full mandate, it's a door for a different way to pay for healthcare, period. And like, does everything need to be covered by insurance? Or does, should we be thinking about cash? Should we be thinking about credit? If we pull it back and think about this is just a financial instrument, what's the most efficient way to pay for different line items of care? That's an interesting question. Right now, you kind of have this weird amalgamation of like everything's under, it's like a group coupon book, right? Of like everything's there. So it unbundles your insurance plan, basically.
Yeah.
Yeah.
Stacy, I feel like we could keep going for hours on this. This has been so much fun. So we'll definitely have you back if you're up for it. But to close it out, where can people find you and Venture on the internet?
Yeah, I'm most active on LinkedIn. Uh, used to post a lot more to Twitter, but LinkedIn's probably the best way to find me right now.
Great. And then is it just venture.com?
Yeah, that's
Great.
correct. Yeah.
Great.
Cool.
Well, I'll include those in the show notes. But thank you so much. We really appreciate it. This was super insightful.
Thanks for having me. Take care.
Thank you, Stacy. It was fun. See ya.
Bye.